On behalf of the diaTribe Foundation, welcome to the 7th annual Solvable Problems in Diabetes, taking place in connection with the virtual EASD. Typically, this event would take place in some wonderful European city. This year it was supposed to be Vienna, but today we're thrilled to make Solvable Problems available to a much larger online audience. Thank you for being here with us. This is I kind of want to say it's live from Leicester. We're not quite in Leicester. I'm in San Francisco, but we have the most amazing group of experts, of clinicians, people so close to diabetes, and people who are of and for the people. So first of all, I just wanted to take a special moment to thank all of them for saying yes long before the pandemic started, and really to take a special moment not only to thank all of the sponsors who have made this amazing event possible, but to really ask us all to appreciate what they're doing. They're investing in areas that truly matter to people with diabetes, and they are making the conversation a really top priority. So thank you to our diamond sponsors, OneDrop and Sanofi. You know, with every innovation, OneDrop really comes closer to kind of achieving its mission of transforming health, changing lives. They're creating opportunities for everybody. OneDrop's kind of digital health platform. It's amazing to see we are going from like a reactive, symptoms-focused approach to healthcare into one where people with chronic conditions, we're all empowered to be more proactive and to make decisions that prevent problems before they happen. I mean, how amazing is that? You know, I think for 35 years, I've always been trying to fix my problems with diabetes, but it's cool that we can think about diabetes in a more preventive way. And so many companies are making this possible. You know, for Sanofi, this company that has developed innovations in diabetes for almost a century, it's been terrific to see an increased focus on innovation in healthcare delivery. And so encouraging to see Sanofi supporting cutting edge conversations like the one that we're having today, these moments, and also to see their huge focus on increased access, which is especially important in the US. Both these companies are particularly devoted to digital innovation, and we're excited to talk about this more tonight in depth. And thank you to so many different organizations for helping us, our platinum sponsors, Abbott, Dexcom, and the Merck Pfizer Alliance, our silver sponsors, BD and Zealand, and our bronze sponsors, Insulet, Crescentio, and Essentia. And it's really the generous support of these sponsors that make the work that we do at diaTribe possible. So ESD is an opportunity for us to reflect on the incredible advances in diabetes and to learn more about incredible research in healthcare delivery taking place, particularly in and around the EU, but also around the world. There's been a bunch of things happening to discuss just the last 2 days. You know, I kind of love, we're moving toward thinking about heart health, kidney health, innovations in coaching and behavior change programs are encouraging this. We've seen stirring evolution in CGM, continuous glucose monitoring. Our competitive landscape on that over at Close Concerns is now 40 different organizations. And what that is powering is all of this, you know, all of this innovation in automated insulin delivery, that's AID, you know, really, those are some emerging triumphs. And we need triumphs across the whole landscape of diabetes, and we need to be able to get them to people. But I would say between what's happening, taking medicine to actually be healthier, on the type 2 front mostly, although in the EU, some of that is on type 1 as well. And then being able to automate the most difficult drug in the world to take is incredible. And we know, despite increased uptake in diabetes technology and access to these continuous streams of data, which many of our leaders tonight have been enabling, there's really been startling information. Some of it's really disturbing, some of it's positive. All of it is illuminating. That has shown a real divide in outcomes. Some people have technology that has enabled intervention are doing amazingly well with managing their diabetes. Some people who have technology aren't doing well at all. And some individuals are able to integrate all of those tools and experience really life-changing results. Some of that we are listening to in the sessions tonight. Thank you again to Miss Sharice Shockley, our incredible community manager at diaTribe. She was running a really cool conversation on tech, and Miss Emily Fitz, head of our policy group at diaTribe, was running one on thinking about time and range. So it's cool to see where it's going. And also we know that we're not seeing all of the successes at the community level, at the population level, across the board yet that we need to see. So the ecosystem has developed unbelievable tools and resources. We haven't yet seen the dramatic sustainable improvements that we expect. And I think for patients, many patients have been part of randomized clinical trial data that's emerging. There's a lot of anecdotal evidence. The challenge has become for all populations to become healthier across the board, to make these outcomes the norm and not isolated events. So we got to keep asking the hard questions. And one of the hardest tasks, which has become even more apparent with COVID-19, is that we need to better understand the disparities in the healthcare systems around the world so that we can advocate for change that will make zip code and skin color, neighborhood no longer tied to health outcomes. The incredible clinical leaders that we're all conversed with today have made it part of their life's work to ask questions. That's what they do. Innovate novel solutions, address the most pressing problems in diabetes, which we know, diabetes is among the most pressing issues in our society. Collectively, these leading clinicians and researchers, there are 4 of them, they've published over 1,500 peer-reviewed publications, many of which are propelling the field forward in transformational ways. They steal time to do this. They buy it. No one is paying them for any of that work. They're doing it on nights. They're doing it on weekends. It's through this work that we find bridges between technology, therapies, data, and real-world results. And at diaTribe, with our efforts in education, advocacy, and connecting the field, we're honored and humbled by the opportunity to bring so much amazing learning to patients, healthcare providers, and researchers. Through collaborations with all of the different stakeholders, we can take strides. We can take all these strides that are being made in research and clinical work. We're going to hear about more of them today, just to bring us closer to these solutions that we very much need across the board. So a couple of quick reminders before I get to do these brief introductions so that we can get to the main points. If you're not familiar with Hopin, here's how it works. We use the event chat on the right-hand side of the screen to communicate with us. We're dying to hear from you, just as we have in the past. If you have questions, if you have comments, if you experience a technical issue, just chat, just put it right in there. Remember, if you write something in the chat, it's going to be seen by everybody who's watching the event. I know that everyone, all of us, will be respectful and courteous, just as you all have been in our past events. At the top of the chat window, you'll also see a tab for polls, and we're going to post questions there throughout the event. So go ahead and try it out right now and tell us where you're tuning in from. Tell us what your relationship to diabetes is. After the panel, please stay on Hopin if you can. Use the networking function to meet others who joined us today. It was amazing. I got to meet a bunch of you beforehand. I think I talked to 12 people in all from 6 different countries, 3 minutes each. You could leave, you could stay. I loved it. I mean, it's like being in community that is really, really that is creating a lot of energy for me tonight and for so many around us. If you can't stay for the whole discussion tonight, we know people need to go in and out. This is being recorded and it'll be circulated to diaTribe readers. So please sign up at diatribe.org/join if you haven't. We hope that you'll spread the word. Again, Sharice is doing an amazing job, our community manager. She's going to be live tweeting throughout the panel. We've seen a lot up there already. That's at #diaTribe Solvable Prob. And please join the conversation on social media if you'd like. You probably saw the pictures circling about our speakers. Their social media accounts are super easy to find if you just go to diaTribe at diaTribe News, our own handle on Twitter. Okay, you guys, I'm so excited to introduce just this powerhouse of a panel. And, to forego some of the formality, diatribe.org/EASD20, you can see more of their incredible credentials and appointments there. So, Melanie Davies is who I want to introduce first. She's a major leading voice in diabetes globally. She's the leader in Leicester and co-director of the Leicester Diabetes Center. For those of you who don't know, this is the largest diabetes facility in Europe. And her exceptional work on type 2 research is particularly renowned. She's done all of these. She's had so much impact on, just so many guidelines, statements, again, publications. She is how we have developed so much of our understanding around SGLT2 and GLP-1, how these therapies have been tested, what they can enable, all about risk reduction. And again, you want to talk about heart health and kidney health, this is who we're learning from. In addition to being such a scientific leader, she's really a public health guru. She's known for so much insightful thinking on prevention, lifestyle, sustainable good health. She's one of the main leaders, the main leader responsible for bringing the renowned 2020, I don't know, is it 29 cities now, cities changing diabetes to the city of Leicester. Such a big deal. Thank you so much for being with us again, Melanie. It's wonderful to see you.
Thanks, Kelly.
And it was particularly wonderful when you were here a couple of years ago with Professor Dan Drucker and Bernie Zinman. So that was all about Toronto. I'm psyched for tonight to be all about Leicester and see what the learnings are that we can bring forth. Next up is Professor Conway Quinte, who is Professor of Primary Care and Vascular Medicine, also the University of Leicester. You and he, Melanie, run the Leicester Diabetes Center. Conway's work is so well known in primary care. Again, super influential in terms of international guidelines on screening, managing people with diabetes, management of people with diabetes. His mark in all of the areas related to primary care and figuring out how to personalize has been so closely followed. Over 800 of those 1,500 publications are his. He is also known for so much on different interventions that are really effective in people related to lifestyle. So it's a big honor, Conway, to have you here and to have someone who influences primary care so completely, and also diabetes, cardiology, and nephrology. So amazing to have you here, and thank you for joining us. I'm glad I was really persistent and that I kept writing you and that you said yes. And now we get to welcome Professor Pratik Choudhary. Pratik is now a new professor at the University of Leicester, having joined there recently after achieving great recognition during 15 years at King's College London. In particular, you guys, he's just a guru on hypoglycemia. There's all this fancy stuff he does with the HypoResolve Consortium. It's PI on so many really landmark trials and work. His work on closed loop in particular, AID studies, really led to the conclusion that unsupervised overnight closed loop delivery at home could improve glucose control in the people who knew it, in the people who needed it best. And it's amazing that we were still thinking about several years ago, what is the biggest impact going to be? And all of that stuff about night and about sleep is huge. So there are very few experts that are at the forefront like he is on the tech side on multiple cures in type 1, as well as right in the heartbeat of so much happening again on diabetes tech more broadly speaking. So Pratik, thank you so much for joining us and being here with us.
Pleasure.
Our fourth panelist is the inimitable Professor Partha. He's a national specialty advisor for diabetes at NHS England. That's the super renowned, influential position in a very select group. Partha's deeply invested in promoting healthcare accessibility and equity, as are all of his colleagues here, the social aspects of diabetes education and integrated care. And he does the work that happens when no one's watching. He recently traveled around the UK right before COVID-19. He visited 115 hospitals, working to learn about some of the biggest challenges. These were challenges, think stuff like inpatient health. What is happening in the hospital? What's going on with foot care? He looked at type 1 really broadly. And he's probably most well known for his tireless work to ensure the availability of CGM in the UK. It was amazing to be watching this real time happen on social media a few years ago. He's equally fiercely committed to bolstering during safety, mental health access for people with diabetes. And his recent leadership and stewardship of national guidelines during COVID-19, during this pandemic, has undoubtedly made an everlasting mark on people with diabetes in the UK. Like I was saying before, this group is they're avid users of social media to engage with people with diabetes, I am often working late in San Francisco, and it's awesome when I see them come online in the morning from England. If you don't follow them already, Run Don't Walk. To do that, you can see their handles again at diaTribe News. In all, I think they've got over 100,000 followers. So I learned heaps from following all of them. So let's jump right in. I'd love to hear from each of you on what you're most excited about in terms of EASD 20. What's one session that we cannot miss? So let's start with Pratik, and then Partha, and then Conway, and finish with Melanie.
Okay, so on my side, I think we've seen a lot of, hopefully that's working out. On my side, I think, of course, the new experience of the virtual meeting is very unique. I think that's very interesting. And I guess the one I've got my eye on actually is the adjunctive therapies in type 1. I think actually now we know that automated insulin delivery works. And I think seeing a few more studies showing that it works as well isn't new. It's nice to see it. I think the adjunctive therapies supporting people over and beyond that is going to be interesting. I'm looking for that session on Thursday morning. Partha.
Oh, for me, it's anything that Pratik is in. Any session he does, I just look forward to it. I mean, it's on my calendar. So I've started from Monday. I mean, just charisma, which I learned from. But I think the main thing realistically is that I think it's a new experience. It's a virtual setting. And I think I really enjoyed listening to bits of Naveed Sattar's lecture, which was good fun a little bit. But in general, I think this is just a new experience for everybody, just to see how people will interact and see how you go. So yeah, in general, looking forward to the whole experience of it.
I've had a few sessions that we've been on, technical problems coming in regularly. I think virtual conferences are not for me, but we are where we are. In terms of what I'm looking forward to, I think we're dipping in and out. Unlike a normal conference when we're there, we'd be engaged constantly for the 5 days. Here, because we've got other work to do, we're continuing to work here in Leicester with our normal activities, so we dip in and out. But I like to look at the trials and then compare that to what's happening in the real world and comparing the two and contrasting the two.
So it's been such a tough 6 or 7 months, and I think many of us have been really immersed in the sort of madness that has been trying to deal with COVID, that actually it's quite nice to have some time to get back into the sort of conference mode, see some of our colleagues, even though it's virtually, and sort of think about diabetes a bit more, which is actually a bit of a nice relief, really. Like Pratik, when I come to these conferences, I like to go to sessions which I'm not necessarily up to speed with. So I tend to go to some of the type 1 work because that's not something I'm so immersed in, apart from when I'm sort of doing my clinical work. But also I'll need to keep up to date with what's happening with the new trial. So I'm chairing the Vertis session, so that'd be interesting. Yeah. And some new work coming out in obesity management, which will be interesting as well. But yeah, it's been such a crazy few months. It's quite nice just to talk diabetes and see some of our colleagues.
Yeah, and obviously nothing is quite the same at all as it was 7 months ago. So much has changed in the world with COVID-19, as you say, including how people manage their diabetes, access care. Melanie, can you help us just with a baseline understanding about the interaction between diabetes and COVID-19? Your whole group has been influential here. I think can be a lot of confusion around that basic question, though. As a patient, is there more that you can say from what you're learning most recently about who is at most risk? What risks are the most addressable? Help us understand the landscape.
Yeah, so I'm sitting here with two guys that have published more on this than probably anybody else in the world. So Kamlesh and Partha have been critical to getting some of the UK data. So I'll give my layman's understanding, and you've got the experts here to add, really. I think what's been clear really early is that there is this link with diabetes, both type 1 and type 2 with COVID. that there seems to be a very strong link with cardiometabolic comorbidities, so obesity and hypertension. I think initially we were all worried about people with asthma and chest problems, but it became very clear that, you know, people with diabetes were hit hard, and we know that around 30% of the mortality was in people with diabetes, particularly type 2 diabetes. From the paper that was published in The Lancet that Partha and Kamlesh were co-authors on, that data, I think, was really helpful because it was across the whole of the UK. We've seen the global data, but it confirmed that you know, that 30% of people with diabetes were dying of COVID. You know, in that cohort, 30% had diabetes. That the relative increase was in people with type 2 and type 1. In fact, the relative increase is in fact slightly higher in type 1 diabetes, but the absolute risk is higher in people with type 2 diabetes, which is sort of what we would expect. I think on a reassuring note, and it'd be interesting to hear their view, is that when you look at the tables, the mortality in people aged under 50, particularly in type 1 diabetes, is well, there were virtually no cases reported under the age of 50. So I think that's reassuring. But it tells us also, you know, there's been other data coming out looking at, you know, poor glycemic control and risk. It tells us that we really need to look after our people living with diabetes to try and reduce their risk. And we need to understand more about what's driving this increase.
Yeah, and that last part is what I was really curious about in particular, you know, like what you all have learned. But Partha and Pratik, your thoughts.
And Kamlesh.
Melanie and Kamlesh, of course.
I'll take that quickly. I think I'll summarize in short. I mean, the COVID basically says that, you know, you've got a higher risk if you've got diabetes. But I think the biggest determinant in there is your age. And I think I always make the case. The problem is when you make a statement like type 1 diabetes has got higher risk, and this is what it first came out. Understandably, and Kamlesh and me got a whole brunt of it, understandably so, from a lot of worried parents and, you know, going, so what's happening to my child now? And I think that's a big message to take away, that, you know, the average age of death in the type 1 population was 72. So age is still the biggest predeterminant of worse mortality. And I always summarize it by saying what we are finding here, as Melanie so beautifully said, you can modify some factors, you can't modify some factors. Work on the factors you can do. You can't change your age, you can't change your ethnicity. Changing your socioeconomic status is beyond the power of one person. That's probably more government level stuff. But you can do something if you try as much as you feasibly can about your weight and HbA1c and your diabetes control. And I think that's the sort of everlasting message we have tried to keep throughout, so to speak. Now I'll let Kamlesh, if he wants to fill in anything else to that.
And the thing is that if you go to the pathway, there's lots of gaps that have been filled. One that hasn't been filled is, do people with diabetes have a higher risk of contracting COVID? We don't know that. That data has not been published as yet. No one's done that. Once you get COVID, people with diabetes, as we've mentioned, have a higher risk. Type 1 diabetes, 3.5-fold increased risk of mortality, and people with type 2 diabetes, 2-fold. The risk is also increased in terms of hospitalization as well, not just mortality. And there's some evidence to show that people going onto intensive care unit are also higher proportion have diabetes. What's been really fascinating, and I think UK and our group was the first one to report this, was the increased risk in Black minority ethnic health population. Because we'd had the COVID pandemic in China, Italy, and Spain, but no one had highlighted this. And one of the reasons is because Black minority ethnic health populations have higher prevalence of obesity, cardiovascular disease, etc. So a lot of good data is coming. I mean, I think UK has the best data, largest data sets in which we publish, with some really nice studies now coming from the Colorado study in France. There's a cohort that they've published on, again, looking at admission glucose and outcomes, both for type 1 and type 2 diabetes. And the association with glycemic control seems to be more stronger with type 2 diabetes than type 1 diabetes. We could debate why so later, but I'll leave it at that.
Yeah, that's so helpful. And Pratik, we just missed you. We don't see your video. So I hope you're going to come back and join us in a second. But
No, I'm here. Can you?
but yes, we can see you now. Thank you so much. But Conway, you having this role as the director of the Center for Black and Minority Ethnic Health, this hasn't been new, that you have been talking about this for a long time. Partha also does a great deal of work in the area. Obviously, a major issue of underrepresentation, BME in clinical research. Do any of you have any thoughts on this, the data that's been collected, and maybe the issue of underrepresentation in clinical research more broadly speaking, and how that's affecting and impacting treatment?
A couple of things on representation in trials. We know we've had an issue in the UK, and we're hearing noises from US as well that Black minority ethnic health populations are not taking part in trial. And Melanie and I have been doing quite a lot of work with our research networks here to identify why. These are very complex. There's a number of reasons, and all different ethnicities have different reasons. It's quite a heterogeneous mixture of reasons, from trust to faith to whether what's it gonna do for me. So I think in terms of the intervention that will be required to get these populations to take part in trials will be very, very different for each ethnic minority group. But that doesn't mean we don't work on it, and we're doing quite a lot of work from the centre to overcome that.
Yeah, so Kelly, can I just add, because Kamlesh is being very modest, but he actually innovated and directs a BME Centre for Health, which is specifically looking at not just community engagement, but also trying to make sure that we get representative groups in research, but also we disseminate that. And that whole centre is really focused on engagement, just not in Leicester. I mean, it started in Leicester in the Midlands, but it now has impact. I think it's been really influential in the national work for the COVID response in the UK.
Thank you so much for that. Partha, anything else on that, or when you were going around to these 115 centers? We know it was pre-COVID, but knowing from that work now, what else do you think? Fill us in.
If I can summarize, I'll summarize my visits. We talk about variations of care. I know there were variations of car park in hospitals. I can tell you that much. In the UK, where it's very difficult to find places to park your car. And that, I say that jocularly, but it probably is a reflection of people with diabetes or anything trying to get to see their specialist. It does have a bearing, when you're trying to get to go in. So there's one. But I think the main important thing I've learned is that there is no lack of desire of healthcare professionals to do the right thing. What I think a lot of people lack is not necessarily the funding isn't there, or you could say clinical leadership. And I don't say that lightly. If you take the UK scenario, you can close your eyes and mention the top 10 centers, right? And you can also close your eyes in the same breath and also you will know which top 10 clinical leaders are linked with those centers. That's as straightforward as it is. Unfortunately, you can't clone a Melanie or a Kamlesh everywhere. Otherwise, everybody would be Leicester, right? That's how it is. And I'll give you one example of that. Apart from the work that we just said before COVID, we actually have just started a review of hospitals as to how they managed COVID-19 patients across the board, ITU, and one of the sections is diabetes. And we've just finished doing Leicester hospitals, which is just come out as one of the best in the country as far as how they manage their acute medical patients, their ITU admissions, and diabetes was actually spot on. So, what we are saying is that in case of a second wave, and fingers crossed it doesn't happen, Leicester is very well positioned, and, the local population should feel, confident that you've got such a good hospital. So that's the thing. It's a question of how do you emulate that good work. So that's probably what I would say is the learning going around the country. It's the leadership, which is very difficult to replicate, not necessarily about let's just translocate one service to another.
Mm-hmm. Yeah.
I think leading on from...
Yeah, go ahead.
I was going to say, leading on from that, I know, the diaTribe, you're very interested in Type 1 and technology. And one of the things that we've done with support from Partha is, after his trips, I lead in the UK something called the Diabetes Technology Network. And what we realized was that there's lots of people who, as Partha said, want to do the right thing, but they have multiple responsibilities: endocrinology, general medicine, looking after obesity, pregnancy, renal, and Type 1 becomes a small part of their job line. And we need to make sure that they have the skills and knowledge available to use these techs. And so we've at the moment, we've just finished filming some 55 videos with the experts around the country to help support both patients but also their health professionals with the right skills and knowledge around being able to use tech and trying to reduce that variation in care.
That's pretty cool, because I think that maybe also you end up flattening the hierarchy a little bit. Pratik, I was wondering if you could say just a little bit more about that, the use of the existing and the novel technologies for care of diabetes. As you say, it's become more important in the time of COVID. Also, just the increased use of telemedicine, CGM, and other technologies. What more can you tell us about what you've noticed, and where have you seen the most exciting advances in tech personally?
So what's really transformed care in the UK has been the widespread availability of Freestyle Libre, and of course Partha had a very strong public Twitter campaign that helped, but also it was getting the money, it was getting the policies right, it was getting the clinicians on board, and then there was a part again that we played in kind of getting the training, and that really transformed telehealth, didn't it? Because we could scroll down our list of patients, see who was struggling, who was doing well, and we could target those people doing well. I think the next step is trying to get kind of a bit more closed loop technology there. Of course, cost and accessibility is an issue, but we're kind of linking the COVID and the tech stuff together. One of the things, again, that we thought was important was prioritizing the ability to see people. And Partha was talking about risk factors that we could control and those we couldn't control. And I think there's also an important role here of using the technology, using the databases, using the data from CGM or downloaded devices to make sure that if we have got a reduced ability to care for people, because a lot of our colleagues are working at the front door looking after people sick with COVID, or the capacity in face-to-face clinics is reduced, then using telehealth better. There's been a huge uptake. I mean, we've heard what would take months to happen has gone through in weeks, hasn't it? And we're all doing virtual clinics from home, seeing patients. But it's also been important to target our time to those people who are most at risk, I think.
So can I just jump in as somebody who's a bit technology challenged? I can't even say the word, so I'm very challenged. But I mean, during COVID, the really good thing is that we've spent years trying to integrate a clinical information system across our specialists into primary care. And we were able to do that in 6 weeks and really get the hospital and primary care. It was very fortuitous that it was right at the time that Pratik joined us. So he was able to drive the type 1 template that we've developed in the clinic, and the use of video clinics. And I think actually technology, not just to deliver insulin and CGM, but technology to engage patients and make care a bit more accessible. So I've been seeing new patients, from their workplace using video links, from nursing homes, and starting treatments and being able to see the primary care information, which even 6 months ago we were nowhere near doing. So I think there's big opportunities to hold on to some of the lessons that we've learned during this crisis.
Sure.
Yeah, I want to just ask Kamesh something about that and then go over to Partha. So Kamesh, we know that you have been very focused on individualizing therapy or technology. It looks like some of the things like, I think you had written about SGLT2s based on real world and clinical trial evidence that appear to save the system money bottom line. I think you had called that cost dominant. Are you working out who should get different therapies based on the technology? And can you talk about technology in primary care a little bit more?
Sure. Technology in primary care, it's in its infancy. I'm sure Partha will agree. We besides technology in terms of the consultations that Melanie's mentioned, that we're embracing that. Other technologies we're embracing. But in terms of CGM technology, we haven't embraced that as well. There's a couple of reasons. One is that the model of care is majority of the people with type 1 diabetes are managed in a primary care, in a secondary care setting, specialist setting. Primary care mainly manages people with type 2 diabetes. CGM has not penetrated type 2 diabetes as much. Partha has been instrumental in getting it to out there for type 1 diabetes, but there isn't much data. There's only one trial which I was involved with, an Australian group that looked at CGM in type 2 diabetes that didn't show an improvement in outcomes. So I think we still need more data to see whether it's beneficial. But in terms of primary care, we do need to learn about technology in terms of interpretation of CGM. And this is where I think our Eden team at our center is playing a big role, especially with Pratik coming to our center to say, can we teach our primary care colleagues on how to interpret these? Because a lot of patients, they'll see the specialist care on a regular basis, but some don't. And they may come with the technology with their readouts to primary care who just wouldn't know how to interpret it. So I think it's still early days, but there's a lot of work that we can do, and I think we are starting that in Leicester now.
Yeah, I mean, I think we've heard so many patients, type 2, type 1, people with gestational diabetes, talk about the power of the arrows, and to know where you want to go, to understand where you are is so valuable, especially if you're using medicines like insulin or like sulfonylurea, that this could prevent hypo and all of that. But Partha, what else do you think on this?
So two main things, and I think the major bits have been covered by everybody who said so far. I think we need to be very careful about technology. Two bits of technology, which I always say. One, be careful that you don't just end up making the good a bit better and not quite giving it access to everybody who really, really needs it. That's the fallacy of technology. And if you look at data in this country from pumps or CGM, I put it as bluntly as you can. If you want to get CGM in this country, and in a country even where it's supposed to be equal to everybody, you have to be rich. Okay? If you want to pump, you have to be rich. Now, it sounds very simplistic, but that's the data. Okay? And that's what we need to be careful with, that you make it equal to everybody. And as Kamlesh's work has shown, Melanie's work has shown, you absolutely need to make sure that the most deprived get what they need. And technology has to be along that lines. The second thing I would say is the other end of the spectrum is that we should not look at one technology and say, that's it. You always have to refresh. Technology is moving and you have to move with it. I mean, everything in life, you need refreshing. I look at, well, let's see Leicester, right? You now have Pratik joining Leicester to freshen up, the new cohort. It's a bit like the LA Lakers getting their new big signing in and all that sort of stuff. But it's important, right, to have the next generation through. And in technology, me and Pratik and Emma, we're all working on one thing. So we've done the Libra. Okay, that's embedded. What's next? The next in the future is, closed loops, right? That's the future. There's no point talking about it. So let's, from a policy point of view, just try and make it happen. Let's be ahead of the curve. And, my policy has always been all chips in. Let's go for it and see where we get to. Even if you land halfway, you've done more than where you started off.
Yeah, I love this. I just want to
just because you've got the medics here, so you've got the four of us, which is great, and Partha is our sort of honorary professor, because we really wanted him as part of the team, but we couldn't persuade him to physically move. But behind that really is, we've got the BME Centre, which is really around community engagement and people living with diabetes. And then there's a whole wealth of people who are real experts as well. We have people who look at physical activity, psychologists, dietitians, a really strong link with our clinical team. And I think it's not just the doctors. You need a whole team of people that are really engaged and working with people living with diabetes. And I think the strength we have is that every day we're either in primary care clinics or clinics, and we listen and have those conversations, people living with diabetes, because you learn so much, and that is what helps us frame the research and then take it back into the clinic. So it's not just the docs here. There's a whole sort of, group of other people that contribute to diabetes care.
I was just going to come in, Kelly, and you've been talking about model of care in Leicester that's worked. And what are the key ingredients? I'd say the key ingredients, I'm sure Melanie and I have talked about this a lot, is that we've got primary and secondary care, specialist care working together, which you don't see that in many other healthcare settings. It's them and us. And here we've got all of us working together. We know each other's strengths. We have the hospital and our clinical commissioning group, which is the primary care side, also working together. When we're developing our pathways, we all sit together and develop our pathways. When we decide who should be managed in specialist care, who should be managed in the primary care, again, that's all thought out as a group. And I think that's what really has made such a success in Leicester, as well as the other members of the group that Melanie's mentioned.
Yeah, and some of that has also come through in cities changing diabetes. Can you all talk about that a little bit? Maybe Melanie first, and then we'll circle back. But it seems like you've got 28 countries all over the world learning. Do you learn from each other? What do you think is being learned in Leicester on that? Could be related to technology, or could be related to built environment, could be related to exercise, but what else do you think that the learnings in Leicester you'd like to be able to share with the rest of the world?
So I think early on we realised that diabetes is a bigger problem than just what goes on in the hospital and primary care. It's a whole societal approach, really, and we were aware that there was this initiative. When we went, they laughed at us because we're not a London or a Manchester or a big UK city. But, you know, Kamlesh and I made a really good argument, I think, that Leicester, you know, it's a very diverse, it's a bit of a microcosm of the UK, really, and it has all the challenges that other cities have. But we felt that we could make a difference because we already had a pretty good infrastructure in terms of primary and secondary care. But we felt that linking with the faith centres, the council, the sports club, would be really powerful, and with all the community groups. So we made a really good case, and we were delighted to get that status, the first city in the UK, and some others have joined now, but we won't talk about them, although we are collaborating. But it's been fantastic. We've learned from cities such as Vancouver, and we've been over to Houston to see what they're doing in their faith centres, and they've been over to us. And it's been great to work with the sports club. So we have something called United Leicester now. So before, the rugby club and the football club and the cricket club wouldn't necessarily particularly collaborate, but they've all come together. So we have a prevention program which is run by the cricket coaches in the basketball indoor arena. So we've got, you know, them all collaborating together, and it's been, I think, really fantastic, actually, and I think it's starting to make a real difference.
Yeah, I think just to add to that, there are a few factors. Said all of them, you know, London were going to be pitching for it, but Leicester is the first city where whites are a minority. 51% of Leicester is ethnic minority. That was, I think, a key factor, a very deprived area. The prevalence of diabetes in Leicester is 8% compared to about 5% in the rest of the country. So lots of diabetes, so you can make a big impact. We're already ahead of the curve in terms of our work that we've done over the last 20 odd years with all the networks that we had made over the last 20 years, including the faith centres, the businesses, the counsellors, the public health, the sports. So I think all of that brought it together, and our pitch worked because of that. And since then, it's been fantastic. I think we've brought everyone together even further when previously they were working in silos.
I'm wondering about, you, Kamlesh and Melanie in particular, have thought about and talked about and researched prevention for so long. The fact that there are some therapies now, as you think about risk stratifying patients, there are therapies that you can take to reduce risk. I think, like, for me, somebody with diabetes, I can't even wrap my head around. Like, I can take medicine and reduce risk. And I was wondering if you could just talk more about your experiences over there on this front, especially since you have all of this real world data.
So I'll start, and I'm sure Kamlesh will add. But, I do think there's a massive gap in terms of even getting the therapies that you talk about to people that should be getting it. So, we are still a way away from that. Our Partha knows, but we're still really needing NICE to update the most recent guidelines around medicine. So I'm not saying that we get it right at all in terms. I think in prevention, there's an awful lot of good data about lifestyle. And when I talk about lifestyle, I'm talking about dietary and physical activity interventions. We do have, thanks to Partha and Jonathan, a commissioned national diabetes prevention program, which is being rapidly adapted to be delivered digitally in the current time. And it's really important to get that message out there. But I think there's a lot of basic stuff that we could do much better, and there's still a big gap. And I'm not sure that it would be right to think about, less cost-effective medicines at this stage to prevent diabetes. I think we've got better, cost-effective, tried lifestyle interventions which we've yet to implement properly, really.
Yeah, well, I was talking in the one-on-one before with an amazing educator from Boulder, Colorado, who was saying this, the walking, and let's work together and let's win the world record of walking with all the people in diabetes in the world. So maybe we'll come back to Leicester from Colorado and see what you think about that. But Conway, again, just going back to that cost dominant idea, I had never really heard of that. I don't know what risk stratification that requires.
So first of all, just to add to Melanie, so I think what you're talking about is prevention as in people with established diabetes. What Melanie was talking about is prevention in...
Yeah, sorry, so I got...
Sorry.
Sorry.
So there's for prevention of diabetes, I think it has to be lifestyle. And Partha works with Jonathan Valabji, who are the national directors, and they, as Melanie said, that England is the first country where we've had a prevention program. It's already showing that there's improvements in weight outcomes, and we know weight outcomes are associated with prevention outcomes. In terms of prevention in people with established diabetes, the ADA-ESD consensus report that Melanie and John Buse chaired, the data is clear. We're seeing even at this meeting, you cannot get any better data than this in terms of improving outcomes for people with established cardiovascular disease and type 2 diabetes, or people with multiple risk factors. But that's not penetrating into clinical practice. And this is what we call the efficacy to effectiveness gap. So efficacy from trials shows that you can improve outcomes, but it doesn't work in clinical practice. And that's the whole kind of work, massive area. One of the areas we've talked about from Leicester is about therapeutic inertia, but it's patient level factors, it's physician, healthcare professional level factors, and system level factors. System levels being things like access. In the UK, we have access, even then it's not penetrating. And so then we go to the healthcare professional level factors, and obviously there are patient level factors such as certain therapies causing hypoglycemia and patients not taking those therapies, so adherence going down. So a whole lot of reasons for this. As I say, it could be a session on its own. Maybe Pratik wants to come in for particularly type 1.
Yeah, so to link that to that one, I think there are three key things I think that are relevant here. I think the first thing is that as data Partha, I'm sure, knows a bit better, the national audit is showing that since we've introduced more access to technology, average HbA1cs are coming down, and we'll certainly see reduction in complications and kind of sort of nasty outcomes that people don't want moving forward as we get better at that. I think the second thing is the work Kamlesh has done in type 2 diabetes on therapeutic inertia. We need to address that question in type 1 diabetes as well. There are some clear pathways about access to technologies based on where you are. And I think that time lag between someone getting onto technology and moving forward needs to be reduced. So I think there's a lot to learn from Kamlesh about therapeutic inertia and apply it to type 1 diabetes. And then thirdly, I think the most exciting thing, I mean, you'll be aware, Kelly, that for the last 25 years, the kind of great and the good have been trying to find a way to slow down or stop diabetes, type 1 diabetes. And I think there's just a few little nuggets of information on the horizon that might show some interest. I think, from a pragmatist point of view, I think it's still a fair while till any of those become routine care, because we still need to know what the long-term impact and safety of those, early studies showing a little bit of protection of C-peptide are, but at least there's something that actually starts to work in the right direction. It's not something I don't think that will become that we should be using in the next 5 years. I think we need to know what the long-term impacts of some of these immunomodulatory drugs are. But in the interim, though, what we know is tight control helps preserve C-peptide, and the later the diagnosis is, the better things are. And I think that's where the kind of technological interventions coming in earlier will help. Partha, I don't know if you want to talk about the impact of the new technologies on the data, the diabetes audit. Oh, you're mute. A pleasure to hear him not hear his sound.
Yeah. So it's okay. It's just because he's jealous of my dulcet tones and my hair. But such is life. So I think the important thing is I've grown to become a big fan of data as time has gone by, especially when you've got access to national data to the extent. So let's take a pause, as I always say. For example, so people talk about we should use this drug, that drug, etc. The median HbA1c of type 1 diabetes adults, right, 18 up in the UK, as things stand, is 8.2%. That's the median HbA1c, okay? If you are below 18, it's 7.8%, which as a population, we got every single person with type 1 diabetes registered, which is a pretty excellent number, right? But the aim is to try and get everybody below 60 if we can, right? Try and get the median down to below 60, which would be amazing for a population. And I think, I can't see any reason why we can't do that, if I'm very honest with you. Now, if you then look at type 2 diabetes, 2 out of 3 people in this country have got an HbA1c less than 7.5%, right? That's 2.6 million people. The issue is there in the type 2 population is actually not with the average. It's with the segmentation of the population where the right groups are not targeted. And that's the issue. So one of the things I reckon that we need to do with data, etc., and the talk about, let's say, using the newer drugs, is are we putting it into the right group? While the approach tends to be let's go for, and that's where the pathways fall down a little bit. And, and Melanie has done some fantastic work on the, pathway in the ADA, ESD guidelines, etc. I'm sure she'll talk about it. That's where we are trying to push NICE towards that segmental. So we've done one step of saying, okay, if you're frail, elderly, we'll change the target. There's much more to be done lower downstream. And I think that's where the focus needs to be. So maybe, today we had a meeting and that's exactly what we are talking about. Do we do segmental data rather than population data, right? People in their first 5 years of diagnosis, 2 years of diagnosis, 10 years of diagnosis, and then focus our attentions there. And because if you bring the median down in people, let's say, in the first 5 years of their type 2 diabetes, you've got a population benefit, right? While necessarily that doesn't happen because the approach is let's go for everybody, where the benefit may not be. And suddenly the system says, oh, we spend too much money. So that's just a thought.
Thank you. Yeah, Project Next. Do you want to go back and talk about any of this related to CVD in type 1? I think we don't hear too much about that. And then go back to Melanie, please.
Yeah, sure. And I think that's quite underreported, isn't it? Because at the moment, everything is linked to glucose control and reducing microvascular complications. And the trouble is, I think, as we've discussed with Kamlesh, is that the numbers needed for these CVOT trials, 10,000 patients. It's not going to happen in type 1 diabetes. So we really need to look at, and that's one of the interesting things, of course, one of the other things Kamlesh does in his spare time is, of course, run the Center for Real World Evidence. And I think pragmatic trials and looking at real world evidence of the use of these novel therapeutics as GLP-1s and SGLT2s are used in type 1 diabetes will become key. And I think that's one of the things that I'm quite excited about, of being able to link my the type 1 diabetes and the big data coming from CGM into those real world evidence databases that Kamlesh has access to. And I think that's really interesting. And of course, Melanie has been involved in some of the key current trials in type 1 diabetes. I don't know, Melanie, if you'd like to comment on the data as it stands today.
Yeah, just sort of coming back to these drugs, the SGLT2s, and to a certain extent the GLP-1s as well. I think there's sort of 3 scandals, as it were, really. One is the fact that even with the outcome studies and the really, solid evidence base, there's still the majority of people are not prescribed these agents for cardiovascular protection, or indeed in those people that have already got established disease. The second thing is that in people under the age of 50 with type 2, only 1% of people aged under the 50 were in the outcome studies. So we've, you talk about type 1, but we've got very little evidence in people with type 2 diabetes who are incredibly high risk if you have early onset type 2. And then if you look at the type 1 patients, of course, there have been some studies with some of the SGLT2s where there was data with sotagliflozin, which I was involved in, dapagliflozin and empagliflozin, which have shown in phase 3 trials that, you can use these drugs relatively safely. There is an increased risk of DKA with some advantage in glycemic control, weight and blood pressure. We don't have the outcome studies for cardiovascular disease, but, you know, we will have data in kidney protection, because in the SGLT2 studies in chronic kidney disease, they are including people with type 1 diabetes. There'll be small numbers, but they will be included in that group. And I do think in terms of cardiorenal protection, we should be continuing to push for some evidence. I agree with Kamlesh, it will be difficult and big studies, but that doesn't mean to say that we shouldn't look at mechanisms and be looking at not ignoring this, really.
In some countries, they have started using SGLT2 inhibitors in type 1 diabetes.
Well, in England, they're licensed, yeah, we can use that.
But the penetration, again, is low. It's not huge numbers as yet. But I think what we can do is, I doubt if there'll be a trial, but one can get real-world data from a number of centers and do a meta-analysis similar to what was done in the CVD Real study, which started with 400,000 people, now it's gone to 800,000 people. And I was supposed to answer your question about the cost dominant. That's where we used the CVD Real study. So we looked at the trials, the EMPEREC, Canvas, and DAPA trials, and then we added the real-world evidence from CVD Real, and the cost-effectiveness evaluation was done using that of SGLT2 inhibitors in the real-world setting, and that showed that when we say cost-dominant, that means it's not just cost-effective, but it's cost-saving. So for people with established disease, it was likely to be cost-effective, but people with multiple risk factors, it's likely to be cost-saving. Now, the problem with all these studies in terms of cost-effectiveness are you model them. And so you have to put a lot of data input. You haven't got long-term outcome trials, but you're modeling that these people will stick to these therapies and they will lead to longer-term outcomes. But that's the best data we have currently.
Yeah, that's interesting. I had never heard of cost dominant before. I loved the way it felt, because it felt like you're kind of helping people, you know, do what they want to do. You're helping people prevent complications. And most of those medicines seem like they also help people lose weight. They help people avoid hypoglycemia if they're not on insulin, type 2s. How do you think that the cost dominant idea might be used in other countries, or have you seen evidence that it is? Do you think you'll be using that more in England? That seems the right way to think about it.
The thing is that it's the payers or people who are making decisions on access to therapies will look at this type of data. This model used a well-known outcomes model, but we added data for CKD as well, which is not normally used. You normally look at HbA1c reductions, blood pressure reductions, and cardiovascular outcomes. But in this one, we had input data for HbA1c, blood pressure, weight as well as the cardiovascular and CKD outcomes, and that's what the results show. I'm not sure whether NICE will look at, you know, every study you look at, you can criticize it, and whoever's reviewing it can criticize it and say this is not the highest quality of evidence, but this is probably the best quality evidence one would have.
It's been interesting to see, especially on the kidney front. I mean, I remember the day that the LEADER data came out in 2016, and I know GLP-1 was really being tested more for safety, and SGLT2s for safety. Which one of the classes have you been more surprised by, and which has been easier? Any thoughts on that?
So I mean, I'm happy to kick off. I think to a certain extent, the SGLT2s were a little bit more surprising. I mean, I think, you know, when people came up with this concept that you give somebody something to make them pass more glucose in their urine, you know, I think we were all a little bit skeptical. And then we had this episode where we had a whole series of Dear Doctor letters about, you know, DKA and amputation and fracture and Fournier's gangrene. And you know, everybody got a little bit spooked. I think as more and more data comes out, it's really impressive, you know, particularly this ability to intervene and delay chronic kidney progression, and really important outcomes for people like preventing dialysis, transplantation, in significant, you know, it's a significant input in an area where we've really struggled to find really good interventions. And I think increasingly, as we get more confident to use the drugs, we're much better at supporting patients. So, for example, during COVID, I wrote to all of my patients who are on SGLT2s to talk about sick day rules, and we've managed to manage people safely during that time with type 2 diabetes, because it's important to maintain good glycemic control with a low risk of hypo and a weight advantage. So, but if you look at the use still, if you look at the numbers of scripts done by cardiologists, it's less than 1%. So we know these drugs are cardiorenal protective, but we've got a long way to go to persuade people like NICE, but also colleagues working in other specialities to be confident to use them in practice.
I mean, if I look at it from a primary care perspective, definitely SGLT2 inhibitors, they've penetrated not as well, but much better than GLP-1 receptor agonists. If you look globally at GLP-1 receptor agonists, it's been a flat line. It's about 6% globally. Some countries have slightly higher, some slightly lower, but overall, globally, it's about 6%. While you see that the SGLT2 inhibitors, the uptake is increasing, and I think that's mainly in terms of people choosing to use SGLT2 inhibitors compared to DPP4 inhibitors because of the cost parity between the two. And now it's getting really exciting. First of all, we used to say that people with diabetes, and then they'd have cardiovascular disease, and we moved from diabetes and cardiovascular disease to cardiometabolic, and now moving to cardiometabolic renal, because we're seeing this triad. So, and some people have already started with the word CARE-ME, cardiorenal metabolic. So that's another. So I think it's an exciting time. We've always said that diabetes is a multi-morbid condition, and now most people are recognizing it. In terms of SGLT2 inhibitors, now we're seeing data in people with and without diabetes. Very exciting area, I think, over the future.
Yeah. I wonder if you have any thoughts on the applications. The applications for GLP-1 have changed a lot, going from twice daily shots to once a week shots. I think there's once a month being worked on. There are oral GLP-1. Any thoughts about what you'll see about uptake in that?
Can I say a couple of things? And I say this as a clinician, you look at all the data, and the data is strong. I think this is probably more a message to the industry. They've got all the strong data. They've tried different things, and as Kamlesh said, it's pretty flat, isn't it? Their uptake. They've tried everything. It doesn't shift. SGLT2 inhibitors come with data, and it shifts. So it's not just the data. I think we need to be very honest about it. The pricing matters, right? And I'll make no two bones about it. The reason we got Freestyle, Libre, and the NHS is because they gave us a drop in price, right? That's what we're going to do with other devices as well. And I think industry needs to think about different other measures. And it could be about, look, our drug is so strong, we would like to look at outcomes and be paid on that. I think you need to move on to that. If you're confident of your drug, I reckon you really need to move to that, because anything else, and all the data we see, it's pretty flat. It doesn't shift. GLP-1s don't shift. And it's not just the injectable side.
But Partha, do you think it's all that, though? Because if you look at DPP4 inhibitors and SGLT2s, where there's not a huge difference in cost, actually, and I do think to Kamlesh's point that therapeutic inertia is actually a complex issue, and it isn't. I mean, I agree with you that the cost does make a difference, but it's not the only factor. There's a perception, and I think also there's a lot around empowering people living with diabetes to ask for these treatments and to really challenge, what is available, because it isn't all about cost. It's about perception, I think, as well. In that if a drug's really easy to use, even if it doesn't have outcome study data, it's used much more than a drug that's a little bit more complicated.
I think there's also a fundamental way in the way we have looked at type 2 diabetes care. If you look back, and I'll be very honest, this is why I chose diabetes before I discovered it was a bit more complicated than this. But then I was too far down the road to change track. So when I was training, the type 2 diabetes was very simplistic, right? Diet, exercise, metformin, glycoside, humulin I, or something as a background in insulatard, and you finished, you packed your bag, you went home. Okay. And the problem is, and I say that simplistically, and Kamlesh will know this, we have talked about this, and a lot of people's mind, that still is the pathway. And that is a fundamental problem. The instinctive nature is, what comes after metformin? What's the drug? Oh, yes, glycoside, isn't it? And it takes a tanker to shift that belief. And, I think for the first time, I may be wrong in this, but I think for the very first time, sulfonylureas are just about starting to show some dips with DPP-4 inhibitors coming up. But we now have a situation, as we said, well, DPP-4 inhibitors, you're going well, actually, we need to move to SGLT2s. And the system is still playing catch up with DPP-4s. So inertia is absolutely, because somehow we haven't quite got, and there is that simplistic narrative, isn't it? And I think one of the people with diabetes said so. Well, type 2 diabetes is all about, just running around and eating less, isn't it? And it's that simplistic narrative which kills it dead on its head. And that's the problem.
Yeah, and I love this piece about narrative and us like kind of singing more maybe from the same songbook. I'm just wondering, do any of you know doctors that have diabetes that take sulfonylureas themselves, or who prescribe sulfonylureas to their family members, or would if it was the same price?
To the mother-in-law.
we're gonna keep going here, but I wonder if you could talk about just like if there's a patient out there, what would be the search for the patients out there that in the audience watching this, what would you suggest people Google after the event is over? What should they learn more about? That's one thing. And while you think about this, Pratik, also we have in the next few minutes, we also love to hear about the Diabetes Tech Network releasing Language Matters video. If you can also talk about that, we're going to go to that next. But specific advice, even given that you're talking about a really heterogeneous audience out there, obviously, but a lot of us have different risks. What advice do you have for people taking the thoughts about their diabetes into their own hands? What do you want them to talk to their doctors about?
So one of the things we did at the ADA ESD is this figure 1 that's in the document, and I suppose there's a couple of things that are in that. Firstly, the person living with diabetes is front and center in the middle of that figure, because and we just need to keep reminding everybody that that's what we're here to do. We're here to support and work with people who are really having to make the decisions. And the other thing we talked about in that was actually the ultimate aim is to reduce the burden of complications, but optimize people's quality of life, because that's what everybody wants to do. And the decision cycle that we tried to put together was that you start with that conversation. And I think as a person living with diabetes, being clear, being able to get into that shared decision making where you're able to articulate what's important to you. And I think, it's really interesting when you do clinic and some of the juniors sit in with you and you start and say, hi, what issues would you like to discuss today? And that's how you start the consultation. We need to get more people to do that, because actually what happens is you go into this sort of, down this pathway, and you don't actually, and people switch off because you've not actually asked them about what's important for them to discuss.
So I think more doctors to start with that. Yeah,
I think it's really powerful actually if you just ask people what they want to talk to you about and what their issues are, and actually, you meet people where you talk to them about what the important issues are for them, and we need to, I suppose, empower people to be able to do that, and we need to get a culture of older clinicians and younger clinicians and the whole team to really give people that opportunity, because it doesn't happen very much, I don't think.
Yeah, Pratik next, but Melanie, how do you do that? I mean, can we put you on a loudspeaker live from Leicester? How do you get out to more people when you're already doing so many things? How can we follow you, and how can patients be of help to you?
Well, I'm useless on social media, so you need to speak to Kamlesh and Pratik and Partha to do that. But I think we've tried to develop our website to put as much on there around the BME Centre, around little video clips around, and we really try and integrate what we do in the research to the clinic and to our colleagues, and we don't always all get it right, and we all learn from each other, and we've all got, as Kamlesh said, strengths and weaknesses. But and I think you constantly learn from people living with diabetes that you see in the clinic. I learn more from them than I do from anybody else, really.
Absolutely. And I think I can tie in a couple of things that people have said. I mean, Partha talked about the narrative, and the narrative of many people's experience of seeing the specialist, who supposedly has the knowledge and information, is coming in, HbA1c not to target, go back, do better, whether that's better diet, exercise, or that's get your A1C better, without quite being told the tools how to do it. And so many people describe on social media or in clinics about, I remember a patient who came in, I said, how's it going? She said, same old, come in, get told off, go away, come back in here, get told off. And that's the narrative that we as healthcare professionals and patients really need to change. And just one of the tools you said, how do we get that narrative going? One of the things we're bringing into Leicester, something I developed when I was down in London, was a consultation tool, which, there's this dead space when people are waiting waiting to see the doctor. We always run late, busy clinics, and engage the mind of that person about what do they want to talk about with their clinician. What are the key 3 things that you want to get out of this consultation? We screen for diabetes distress, and we thought we were very empathetic in the way we approach patients, but actually seeing someone score a 5 or a 6 in that very simple screening tool made us change the way we approach that question. So your HbA1c is whatever it is, but you're scoring very high on the distress. Why? And when we started swapping that conversation to say, well, if I can get your A1C down, the distress will come down, and converting it to saying, well, if I can address your distress, the A1C will come down. Actually, we have some data that came out, we presented at the ESC last year, showing about a 0.5% drop just by changing our approach in clinic and using these really simple tools. And so some of these are the ways in which you bridge that gap between what the evidence says and the art of medicine, and how you deliver it into clinical care.
Yeah, just a quick follow-up on that. So, maybe the A1C doesn't change that much, but you're one of the world experts on hypo. Are you looking at the time in range data to see how much hypo there is as more and more people have gotten access to this amazing tool of being able to look at their diabetes that way? Is that becoming more normal, and what's that like?
Yeah, I mean, so I think from a long time ago, we started using actually proportion in range before we had CGM with our downloads. Everyone was downloaded in clinic, and even with finger sticks, we just started talking about proportion in range, and then that moved very seamlessly to time in range. And of course, we all find that that's a much more relatable term, isn't it, than the A1C, which is this mythical beast that comes out of your finger every 3 months, and then the time in range is something that you see on your device straight up. So it's really changed the narrative, and people. The thing that has struck me the most is when I've asked people, so how many of your readings do you think you need to get in range to hit that magical number of 7%? And people come back with the thought that it's got to be 90 or 100%. And when you say it's like kind of 65, 70%, and you've got an allowance of 25%, 30%, that if it's not perfect, it's okay. And you can just kind of see, okay. Yeah. And don't panic every time you see a number that's over 180, over 10, and you've got some time. That's been the impact of time in range for me, actually.
Yeah, I was floored when I found out that just 5% better. That was an hour more a day. Yeah. But Partha, thoughts on this? I thought so. You're going to jump in there.
Yeah, I mean, I think it's been a learning experience for me. I think the whole interaction. We use social media. Kamlesh uses. I think a lot of the things you learn is about, we talk widely about flattening the hierarchy, but I think I've learned a hell of a lot as you pick up from social media. And there'll be the odd people who are angry and they've probably had an issue with the healthcare profession. That happens. But the majority of people with diabetes have been very kind, and they've been great with their suggestions, tips, what needs to change. We did the work with a lot of people concerned about language matters, and it's now spread. We've done a Spanish version. We worked quite a few across. We've taken it to India. It's been just fantastic to see how many people have been interested in it. And as I keep saying to people, this is not a debate about, is it a diabetes person or a diabetic person? That completely defeats the whole. This is about just having a human conversation with somebody who's living with something you don't have. That's as straightforward as it is. So somewhere down the line, I think maybe that got missed. And I think people with diabetes have said it loud and hard enough. And it's our job to sort of listen to it and do it accordingly. So we're all learning. And as Melanie said, it's very easy to create how shall I put an image on social media of everything being perfect and infallible and never quite getting it wrong. I can assure you, for every single thing that is delivered, there's 10 things that are not delivered or failed. So, that's the way it works. So great learning curve as far as I'm concerned on all quarters.
Yeah, I love that. I want to go to some of these related questions from the audience, and thank you so much, everybody, for giving me these questions. I want to go to Anthony first. Said, do you feel that there are appropriate technology tools or feedback mechanisms that help people identify the impact of actions such as exercise, nutrition, lifestyle, work, etc., on their blood glucose levels? If you guys can talk a little more about that.
So I guess I'll take it, and I think from what I've seen at the moment, no. I think, it's so variable about how every person reacts, and each person reacts differently. But what will help that is the more data tracking we get with devices, like I wear an Apple Watch. Once you start tracking more data, I think we'll start to learn a little bit more. But then at the end of the day, when you take 3 steps back and you see what's happening with closed loops, you think, well, do you really need to know that? You respond to the glucose, adjust the insulin, and it seems to get people in range. So I think there's 2 approaches to that. So I hope that makes sense, Anthony.
Yeah, so I think for people with type 1 diabetes with the CGMS, it's getting better now. But I think there's still a massive gap for people with type 2 diabetes. And I think that being able to monitor and giving people feedback, whether that's their well-being and psychological health, or it's their steps and physical activity, or it's their sleep. I mean, there's a huge interaction with sleep and glucose control and type 2 diabetes. So I do think we need much better ways of monitoring people's 24-hour profile to be able to give them feedback to make changes. And we're still a long way away from that.
I was wondering if you could all talk a little bit about social media. Melanie, I know you say that you don't do that much on it, but how can you not, being influenced by the other 3 here? Maybe we start with Kamlesh. How did you get into it? I think I see you maybe you're up the earliest, I think, of everyone, or maybe working the latest, I guess it would be. But I'd love to hear about stories there.
So Melanie and I came into social media very late on, I think. Probably about 4 or 5 years ago, before the Diabetes UK meeting.
You've embraced it much more than I have, though.
Someone taught us about it. I've learned a lot from Partha. He's the king of social media, obviously. But Partha has a fantastic connectivity, and I'm sure he'll come into it. He has a fantastic connectivity with people with diabetes. I probably have a more connectivity with healthcare professionals. I do mine literally just morning and at night. That's what you'll usually see from me. And it's usually, I just look at the evidence base, what's been published, and I just put what's of interest to healthcare professionals. And that's how I normally use social media. I think Partha shouts at me sometimes because past 6-7 months, all I've been talking about bad news about COVID. Very little good news. So he keeps nudging me every now and then, says, that's bad news again, So I'm trying to get into better news, but we haven't got any good news on COVID as yet. But as soon as it comes, I'll be out there.
Yeah, I found that Scottish data from you the other day, Kamlesh, and we tried to blast that out to people. And I think they call you King Kamlesh anyway, don't they? So you're all over social media. But Partha and Pratik, any comments there as well?
I think social media are great. I'll go first and you can finish off, Partha. Just to say that I think I do 2 things. I put it in my appraisal that if I just follow Kamlesh every morning, then I don't need to, then I know exactly what's happening in the world of diabetes, and it's my continuing professional development from an academic perspective. And that's really helpful. And then the second thing, I was asked to talk about social media, and I called the talk the reluctant twit, because I joined social media just to kind of follow sport and do the normal things people do. And then I got sucked into the education I got from people with diabetes, actually, and interacting with them. And so it's kind of this 2-edged thing with a bit of academic side getting and getting it from the patients as well. I think I'm trying to merge those 2 things. Partha, we will just follow Partha though.
Yeah, I mean, I think the role has changed. I think COVID-19 pandemic, I saw my role as more to try and give reassurance as much as possible. I think that's been pretty much what I've tried to do, go out and say, look, this is what we're trying to do, this is what we're trying to set up. I try and sort of be as positive as possible. I rarely put out negative things in the sense that, news is negative, but I think it's about, as I said, trying to do the modifiable. And again, just give you an example, Kamlesh this morning tweeted about Italy, the data come out, and amputation rates have gone up. But this thing that I straight away said to them, we have done exactly the data set and our amputation rates haven't gone up. And the reason for that, I think, is because we went first of the ranks in March and we said, whatever you shut, you do not shut foot clinics. Foot clinics got to run, okay? Maybe it's not that. I don't know, but it's not gone up. And I think that's the thing that I think the social media, a lot of people come to that. I don't just use Twitter. I use nowadays Instagram. I use Facebook. A lot of it is about just messages saying, don't worry, NHS is here. We can do that. I think it's a good thing. Plus, and then there's always dog gifts and fun stuff. And I love my movies and, all that sort of stuff. So yeah, it's good.
So I'm a passive social media user. So I follow Kamlesh and Pratik and Emma and Ab and others to sort of get all the latest. It's a very lazy way of keeping up with
me
all
too. She hasn't mentioned my name. She follows me too.
The reason I follow you, Partha, is because it's a really powerful way of hearing what's going on from people living with diabetes perspective. And I'm not great. I'm not very good at sort of constructing the tweets and doing it, but it's a really good way of getting what the issues are, because you can validate that when you speak to people in the clinic, but you can then see what's also going on. So I do think it's very valuable. I just find it really difficult technically to do it because I'm old, I'm afraid.
We're going to do a lightning round now. We're going to go through questions really quickly because there's so little time left, but this has been so valuable. So Partha, the next one is about low carb diets for people with diabetes, and we're going to do 60 seconds.
All right. Am I going first?
Yes, just you on that one, and then we're going to.
Oh, just me. Okay. Very simply, any diet works if you can tolerate it, sustain it, and afford it. I have no problem with any diets. If you want to carry on with it and it works for you, please do. If you can afford it, brilliant. I think that's the main thing. As Michael Marmot said, and Julian Tudor-Hart has said, if you really want to live long, you need to be born rich. That's the unfortunate situation in the world, and that's what we need to change. So I can't put it. I really don't mind a low carb, low cal, high fat. You can eat whatever you want. Or as James Cracknell is right now doing, not eating anything for 5 days. Evidently that helps with your diabetes as well. Well, whatever suits you best is what I say.
A lot of people we can learn from out there on food. Pratik, the next one, can you comment on the acute and chronic effects of hypos, and if there are any thoughts on, brain fog type 1? That's hard in 60 seconds, but it's
hard in 60 seconds. So I think the acute, everyone living with diabetes is aware of the acute effects, how you feel in the acute stage. I think in terms of the long term, actually what the data is pretty strong on is running an HbA1c high is bad for your brain and it's bad for IQ and increases the risk of dementia. And that's pretty clear. Actually, the brain is pretty robust in response to the low readings that you get. I think once you start crossing multiple severe hypos needing support, those are the sort of people where you start seeing some challenges in the brain. But actually, I don't think short-term low center glucose events that you're asymptomatic from actually have a big impact.
Oh, that's a relief for a lot of us. Here's the last question, and I know everyone joins me in thanking you all so much again. What does each of you think can be done to reduce the variation in care among people with diabetes and create greater equality of care and health? And we're going to start with Melanie, and then go to Kamlesh, and then go to Pratik, and then go to.
Oh, such a difficult question. I think it's about access and equality. And, I think Partha said it a lot, really. It's social deprivation and certainly in type 2, that's the area. So I think making equitable care and access as easy as we possibly can.
One thing that COVID has taught us is that deprivation is the biggest risk factor for morbidity and mortality. We knew about that then, but COVID's highlighted even more. And we know ethnic minority groups mainly live in deprived conditions. The only way we can close this gap is, first of all, getting the data and getting ethnicity data to that very small level and having that data published on a regular basis and putting in interventions to close that gap. We're not going to get there otherwise.
And I think what Melanie and Kamala said, very important to get the healthcare professionals and the payers and funders on board with reducing variation. But I think what organizations like diaTribe and yourself are doing, increasing awareness among patients about people living with diabetes, empowering them to say, what is the guidance? Why am I not getting this therapy? What is the best thing for me? I think that pincer movement of getting the healthcare professionals in with the data, but also the patients in with awareness, is going to be really key. But it's again the same thing. It's about those are the people with diabetes who are least likely to get reach, and it's about how we do that together.
Yeah, as far as me, I'll echo everything that's been said, but I'll add one more thing. And this is probably a message to every single person in industry sitting here listening, whether you're in technology industry or pharmaceutical industry. In the UK, if you want to have access to the market, then you need to have plans whereby you get it to the deprived population. It's not just my job to do it, it's your job too. And that's a conversation we have had with Abbott very clearly about the Libra, which we managed to now get it beyond the socioeconomic deprivation. And that's the message. For you want your drug or your technology to be here, I'm not going to do that just to make the good a little bit better and the bad worse. So you bring a strategy, and we are very, very happy to listen. It's a joint effort, but it has to be done as a priority.
Yeah, and it's amazing to hear you say that, Partha, because also what you have enabled. Of course, the volume has gone way up, and that's amazing to see. And of course, all of the news on CGM and what CGM enables and automating insulin and all of that. I mean, it is just building a much bigger ecosystem. So the global pricing, there's been a lot of success. I also want to say that, there are a lot of companies out there who are doing, 166 vaccine programs. The funding for that has to come from somewhere and all of that. And so, this multi-stakeholder could not be more important. And watching all of you do this, live from Leicester, I mean, what an amazing, amazing set of examples. I have the most exciting news, everybody. Some of the panelists are going to be able to stay on and go to networking. And if you haven't tried that, I got to talk to 12 different people right before the session started, and 12 people from 6 different countries for 3 minutes. It was amazing. And some of them are able to stay on. So, we're so grateful that you all took time this evening to learn with us. Questions and comments and interaction in the sessions and interaction in the chat and interaction on Twitter, hashtag diaTribe solvable prob. To me, that's just another reminder of the power of community. And, that is what these phenomenal panelists are all about. What an engaging discussion. So again, hang out on Hopin. The networking app is going to be open for another hour. You can meet some of the people. You can also go to the expo hall if you'd like to do that. diaTribe.org/join is what we'd love you to do to help us share more about diabetes. diabetes.org/TIR, diabetes.org/COVID-19. Follow us on Twitter and Instagram, and follow Sharice Shockley. So what an amazing, amazing event that our team has helped me do tonight for diaTribe. Endless thanks to all of you. We at diaTribe are sending you lots of love and power during these very challenging times. Lots and lots of food for thought.